like 2 in the morning. I'm on call right now. It's Dr. Pinesett, the Premed productivity expert. If you don't know, uh, this is a random live video right now. If you guys also don't know, I'm live every Sunday at 4 p.m. Pacific Standard Time, giving you guys great advice and strategies to get you to medical school and make you be better students. I also have a new upload every Tuesday and Thursday at 5 p.m. Pacific Standard Time. And tonight, guys, you're going to hear I'm in the middle of a call shift. I actually have a couple more hours left, but I have a 24-hour call shift covering as an anesthesiologist covering the ICU and the trauma bays here in San Diego at the #1 trauma center in San Diego. And actually, I think mostly in Southern California, we're a big dog. We got all of Mexico, and we get all of San Diego and a lot of Southern California. So I'm gonna tell you guys about my night, my evening. Po, hello. Um, so it's been crazy. If you can't tell, I've yet to sleep. Um, I'm in the call room right now, um, waiting for the next pager to go off. Carrying my mini pagers. Yes, Devin, you're catching me live. Darren, what up? So here's what's happened. Here's what's going down. If you can imagine this. So if you guys don't know, try to keep everybody up to speed. I am an anesthesiology resident, University of California, San Diego. Oh, Richard, what up? Okay, thank you. Help me out. Got to clarify whose YouTube name these are. So I'm a resident at an anesthesiology resident at a major trauma center in San Diego. And what a lot of people don't recognize, I think this is the first thing I want to say in this video, is most people assume that surgeons and those people are the ones who deal with the sickest patients, who deal with the ICU, who deal with the traumas. But the reality is that anesthesia is at the center of all these situations because anesthesiologists, for starters, we're the only physicians in the entire hospital who are able to push medications. And so that makes us crucial for critical situations where you need medications pushed quickly, pushed right to support critically ill patients. Additionally, as an anesthesiologist, we treat the sickest patients of all in the operating room, and we treat them with medications that are life-saving, that are life support. And so what ends up happening is that we are very well versed in dealing with people who are on the precipice, on the cliff of dropping off. I mean, I actually had a scheduled case in the operating room yesterday, 2 days ago, Thursday, um, and my patient's blood pressure coming into the operating room was 90 over like 20 over 80. This person came in at 90 over something and they dropped their diastolic was in the teens, like 17. And that sounds very scary, and it is scary, and you bring the pressure up, but that's something that we see routinely. What is abnormal to most people becomes normal to us. And I think one of the I'll get to the highlight of the night right now. We'll start off with that. You guys want to hear the highlight of the night? Is that I'm an anesthesia resident, so I'm still in training. But as anesthesiologists, we are the absolute masters of the airway. When it comes to intubating patients who need airways because they're in respiratory failure, whether it's hypercapnia, whether it's hypoxemia, whatever it might be, when you need an airway, you call anesthesia. Additionally, when you need IV access or line access, central lines, arterial lines, groin lines, whatever you need, you call anesthesia. We put those lines in for you, help you out. And so I got paged about an hour ago, and that's what kind of inspired this video. I was like, man, people have got to hear about this kind of stuff because I think it's interesting. I'm in my second year. I'm in my third year of residency, second year of residency. If that makes sense. So I did an intern year that was a general intern year, and then I'm in my second year of focused anesthesia, and I have one more year to go. So woo, almost done. But we're the masters of this airway. And so I got called by the pulmonology attending who's currently staffing the ICU. And he was asking if I could supervise him and his fellow and their resident doing an intubation in the ICU. And that may sound strange, right? Why would an attending and a fellow call a resident to supervise an airway? And it's totally logical, and I respect them for doing the right thing, which is calling us because we are the experts. And so getting that extra set of expert eyes to help guide you through the process is incredible. And so we had this patient who is a very large patient and big patients. So what would you guys think? So if you have a patient who's in hypoxic respiratory failure. So they don't oxygenate well. And then you hear the person is 400 plus pounds, like our patient just was, right? So this patient is called 425. You have a 425-pound patient who's in respiratory failure and you have to intubate them. Is that concerning to you? Is it more concerning to you than if they weighed 50 pounds? What would you guys think? I'll wait for you guys to comment. What do you guys think? Candy Davis says, yes, that would be concerning to you, right? Lots of pressure on the trach from all the weight, right? So if you guys imagine, it's like someone sitting on your chest or sitting on your stomach when you're trying to breathe, it's hard to breathe. Well, it's just as difficult for us to push oxygen against that kind of weight. Because the same thing as you pulling in air with someone sitting on your chest, it's the same thing as us trying to push air in. So when I see a very big person, I assume I'm going to have a more difficult time than normal pushing air in if they're not intubated and ventilating them effectively. Additionally, when you're big, right, that's more tissue that you have to feed, right, and fuel with energy. And so heavy set people burn more calories, right? They're big, so they use up a lot more oxygen quickly. And so if you don't oxygenate a heavy set person well, they'll desaturate faster. And we plot out all these curves and everything. And the normal person, this is also shocking. I didn't realize this until I became anesthesia. You can go a very long time without breathing and survive. And so the average person, you can go like 8 minutes before you really start to get to some serious hypoxia that really matters. You can go a very long time. And with obese people, it's actually like a quarter of that time. So it's like 8 minutes for you guys who are normal. And then for people who are obese, it's like 2 minutes. And so it's a very, very scary situation when you have a very heavy set patient who's already ill, who's already acidotic, who's septic, who has all these things going on, and then you have to come in and save that airway because so much can go wrong. It's also a lot of tissue here, right? They can obstruct, right? So when you're heavy set, you're more likely to be obstructive sleep apnea and have all these things. It's hard, right? So I go in this room, I'm gonna supervise, and I'm trying to stand back and be calm. And you guys know me, I'm kind of crazy, but I'm trying to stand back and I'm trying to stand back and let this team go and set up everything they're doing. And they go to do their thing and start to intubate, and they're walking through the process and they're doing it, and they can't get the airway. Resident tries, fellow still trying. All the while, the patient is desatting, 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 desatting. And I'm getting closer and closer to the bed because I'm like, oh my gosh, this patient is desatting. You guys are struggling to get the tube in. And the patient, you guys know, right, 100% saturation is good. 90% saturation is not so good. Well, this patient got down to 47% saturation. When I stepped in, the patient was at about 60% saturation. I said, okay, guys, I'm taking over. I then, right, picked that jaw up, dropped the tube in, no problem, started bagging him up, bringing it back up, and the lowest it got was about 47 saturation. So it's very, very scary, and it happens very, very quickly. And if you don't get that tube in, you start to put yourself in a situation where brain cells, heart cells, right, critical tissues, you can cause ischemia, right? Brain ischemia is your stroke, heart ischemia is your heart attack, and in someone who's already, right, septic, which means that they have poor perfusion to begin with and poor oxygenation. And when you couple that with poor oxygenation in the little bit of blood that does get there, it's hugely problematic. You're gonna have people have massive heart attacks from being poorly ventilated. And so put the tube in, it was all good and brought it up, but it was just an interesting situation because then after that I was like, listen guys, let me give you guys some feedback. And I was trying to give them feedback on what they were doing. I was like, yeah, you guys were doing good stuff, but here's what you have to do. And it just made me really reflect on how far I've come in my training, that I truly feel there's very little that makes me nervous, which is crazy to say, but it's like you do enough cases. And tonight I've been in the operating room all night. I was not in the operating room all day. I was mostly going around the floors, but all night tonight, we've had like 5 or 6 cases in the operating room. It's just random traumas or different things. And you get that page, and the pager goes off, and you're like, either sleep or you're relaxing and you're trying to chill, and the pager goes off and it's like boom, and it's blowing up. and then you're jarred awake, and you try to see what's up, it's like, oh, it's the code pager, oh, it's the trauma pager. And you have to run down to the trauma bay, and the trauma bay is an interesting thing. I don't know if you guys are familiar with the trauma bay and what that's all about. Um, so, what do you do to use to measure oxygen saturation? Use a pulse oximeter. So it's that thing when you go to the doctor and they put that little thing on your finger, and you start to hear beeping. That's another thing. I didn't. The beeping you guys hear is not from the EKG. It's actually from the pulse oximeter, which makes sense. Pulse oximeter. How do you remain calm in a situation like that? I think it's both experience and preparation. And this is what's interesting. So often, right? I always talk about test anxiety. I always talk about test anxiety. And I'm like, test anxiety, guys, is a result of your lack of experience and preparation, as Candy was just talking about. When I walk in situations, I'm calm because I've seen 1,000 of these things. And I'm very thankful to my program here at UCSD because there's multiple ways of training and doing different things. And often it's our comfort zone to be eased into things, right? We always like to, oh, I want to just start off slow, learn the basics, and then, as I progress, I want to be challenged. And what UCSD's philosophy is, no, we're going to throw you to the fire, into the wolves, and we're going to have you taking call from like your second month. Like, most programs don't take call until their second year. We take call our second month. And not only do we take call at a major trauma center. We get Mexico accidents, we get San Diego accidents. People come from LA, people come from the desert. We get all over who come to our centers. So our call shifts are extremely busy. We see much more trauma, hearts, stabbing, shootings, all kind of stuff that people otherwise don't get this experience. So I'm very thankful to our program, UCSD, shout out UCSD, for giving us this tremendous exposure because the stuff I saw in my first couple months, after seeing that stuff, it's like, nah, okay. I dealt with the person who had no neck. I literally had a patient come in to the trauma bay. They had a neck tumor previously. They had an incision that went from here, down here behind the ear, down their neck, down the front of their neck. They had flapped it open to pull the tumor out, and they had closed it up, sent the patient home. Patient came back into the ED because a hematoma had formed. So there was bleeding going on underneath this flap, and the bleeding got so bad, right, that it was swelling out. So they were coming to the ED. And on the way to the ED, the flap, because there was so much pressure from the blood, actually burst open. And when it burst open, it's kind of crazy. It was sutured down. It actually pulled the side of the trachea with it. So what was really interesting was everything was exposed right to the trachea. I could see this person's windpipe, and there's bubbles coming through the blood, which tells us that the trachea is open. And this is in my second month of anesthesia ever, and my technician's like, "What do you want to do?" I'm like, "What do I want to do? I want to go cry in the corner. What are you talking about? I don't know what I'm doing." And he's like, "No, take a second. It's the same thing as if it was a healthy patient. Walk through what you would do. What's your airway algorithm? What are your options? What are your priorities? What are you trying to do? Like, what are you worried about?" And we just talked it through as this person's bubbling right away in the blood. And I took care of this patient in my second month who had no neck. His whole neck was pulled off. He's bubbling into the blood in his neck. And you have to go and do it. And Devin said, how do you not take blood in the airway? And actually, he was putting blood into the airway. And so this was the other thing. So then I go to DL, right, direct laryngoscopy. I put the blade in to open the mouth up to put the tube in. And as I do that, blood comes rushing up out of me, right? Because I've changed the pressure gradient for my physics people, right? There was lots of pressure up here. He was obstructing. I then open it up. The pressure gradient has changed, and now the blood is free to flow from the neck up the trachea and out the mouth. And so now blood is coming at me. We stick in dual suction, right, double time, suction on each side, give yourself a little bit of path to see, and you just pop the tube in where the bubbles are, and I put the tube in. And I was like, holy cow. I just intubated someone who had no neck, whose airway is drowning in blood, and I put a tube in. So then after that, I'm like, if I can stick a tube in that, I could probably stick a tube in pretty much anything. And so your level of nervousness kind of goes away because you're like, oh wait, the person's breathing on their own? What? They're super skinny? What? They're not bleeding to their airway? This is wonderful. I can go do that. And so you develop this confidence and this calm that other people may not have. And so I think it's really interesting. We always kind of crack up at anesthesiologists because we get us. When stuff hits the fan, when someone's very sick, when anything's going down, we get the call. And it's interesting because we'll go to these things outside the operating room. We'll go to a code situation. We'll go to someone who's near coding, someone who's in respiratory failure, someone who's having a heart attack, someone who's doing all this, and we'll go. And people are losing their minds, freaking out, very nervous, very anxious. And it's like all this stuff going on, and the anesthesiologist stays calm. And there are surgeons who work in trauma, there are non-anesthesiologists who work in the ICU, and what you notice amongst these collective people is that they're all very calm. Worry wart, right? If you're a person who's very anxious, if stressful, fast situations make you very nervous, um, it may not be the area for you. With that being said, it's like people who say, "Oh, I'm squeamish about blood, so I shouldn't go to medicine." Exposure makes things normal to you, right? So me, blood is nothing to me. Right? I get blood on me on the regular. I got my Crocs. I wear Crocs every day at work, and I have to rotate my Crocs and buy new Crocs all the time because I'm constantly getting blood on my shoes. And I should wear shoe covers, but that's inconvenient. They tear and all this kind of stuff. So anyway, but blood is something I see and experience every single day. Every single day, without fail, there's lots of blood all over the place. And you just get used to it. Something like, okay, so this is the other side of this. So something I was always very squeamish about was poop. When my wife and I got together, I was like, oh, I'm not changing any poop diapers ever. Like poop, it's the worst. And then now I see so much poop because we do all these, like, people perf their bowels, and so we get poop all the time. And so I'm like numb to poop. It's like, oh, it smells like poop in here. Someone walking, I'm like, I don't even smell it. My nose has learned to clamp down when poop's alive in this place. It's the same way with blood. It's the same way with critical high stress situations. Is you get exposed to it enough, and your adrenaline level, it starts to come down because it becomes the baseline where you function at. Right? It's like military people. It's like firefighters. It's like people forgot about fire, but if you're a firefighter, you're used to running into flames. So no longer are you scared of the fire. You deal with it, right? You're able to cope with that fear and get through it. And so I think the lesson for you guys is exposure, practice, familiarity. When you're working your problems, when you're doing your homework, get familiar with it, right? Ruminate on that stuff, right? Get experience. I see so many people who just kind of dabble in their homework and they do a little bit here, a little bit there, but it's the immersion, it's the repetition, it's doing problems over and over again until it's like muscle memory, until that math problem doesn't make you anxious, right? You shouldn't be nervous going into your tests. You should be calm and smooth and have plan A and plan B and plan C and all these kind of things. And then when you do that, and people always ask me, like, how can you say that testing and studying is fun? It becomes fun when you get at such a high level and you have so much experience that you know you've already won. Like when I feel like about the airway, like there's no airway I feel like I can't get. I take my time and walk over there like I'm calm because I know I'm gonna get the airway. Airway can't escape me because I got a plan A, plan B. Oh wait, I can't get DL. I'll do a fiber. Oh, I can't do the fiber. Okay, you know what? I'm gonna go to my bougie. Oh, I can't do my bougie. Okay, right. I have all these steps I'm gonna walk through. Get my LMA in. Okay, I'm gonna mask vent, two hand. Get another person. Now we're gonna do forehand mask ventilation. I have all these steps I'm gonna do to make sure that airway can't get away from me. And for you guys, this is the same way I approach studying and testing, is that I'm gonna have everything covered. The same thing with medical school admissions, right? So right now, you guys are going to apply to medical school. And you're wondering, oh, am I gonna get in? Am I not gonna get in? You're nervous about it. And the reality is I wasn't nervous when I applied. And many of my students aren't nervous. Many of them are, and I have to reassure them. But I can reassure them with confidence, like, oh, you're gonna be fine, you're gonna be good, you're gonna be great, because I know the process. I'm that familiar with it, and I've worked with them on improving themselves. And so I encourage you guys, if you're nervous going into the application cycle, that means that some part of you feels like, ooh, maybe I didn't do everything I should have done. Maybe I could have tried a little bit harder, and you start to see deficiencies in where you're at because you didn't develop the level of preparation that you should for this application. So anyway, I think I'm kind of nerdy that way. I kind of geek off of these kind of high stress situations. I love it. Um, do I wish it wasn't 2 in the morning and I was doing it? Yes, but I think it's just something that becomes your norm. And if you guys talk to like ED physicians, if you guys talk to trauma surgeons, if you talk to critical care physicians, talk to anesthesiologists, they're gonna tell you like our norm is well off the curve, and it becomes fun when you become proficient, and when you have the experience and you're prepared for these moments. It's just routine. It's just rote. I can intubate in my sleep backwards. And now I even get kind of crazy with it. So this is how like, right? This is how you know you're sick, right? When you have that sickness, when you're over prepared, is now my thing to do to continue to develop my skills is I know how to optimize the patient to make my airway the best it could be, right? Now I go into rooms and I intentionally sabotage myself. So instead of intubating from behind the head, I'll intubate from the side of the patient. And I'll just like throw a claw over and do it like blindly, right? Or I won't ramp the patient, or I won't do like, I do all these things to sabotage myself. I try different blades out. I do an oversized tube. I do all these different things to put myself in less than optimal conditions. So that way I'm stretching my skills for when I actually do need to do those situations where I can't get to the head of the bed, where I can't ramp the patient, where I don't have time to pre-oxygenate, where I have all these things. I've already run them through in safer scenarios and stretched myself so it's not something new to me. Yeah, Mach K 55. I am on hour, I don't know, what time is it? Someone tell me what time it is. I don't even know what time it is in this place. While we wait to figure out what time it is, today, as in Sunday, at 4 p.m. Pacific Standard Time, you're not going to want to miss the live stream. I'm bringing you guys lessons from my Mount Sat keynote on Friday. I had some nice conversations. I'm going to bring you guys some great lessons on that. And we're going to talk about how we set our goals as pre-meds. And we're going to talk about how we exceed those goals. And it's an awesome talk and about getting your mindset right to make the changes required to get to your goals. So it's going to be a great talk today at 4 p.m. So I'll see you guys at 4 p.m. for that. It's 2:22. All right, so it's 2:30 in the morning now. So I am on hour. I started this morning at 6 a.m. So how many hours is that? 20. 20. I'm on hour number 20 right now. No sleep, rolling, no coffee, no caffeine, just high on life. High on life. Any other questions about this? Was this helpful to you guys? Was this interesting to you guys? Maybe because it's 2 in the morning, I don't know what I'm talking about, but um, it's definitely crazy. You see lots of crazy stuff. And I actually saw something. I was on call Thursday night, and I had to go home and tell my wife. I was like, holy smokes, I saw something today that shook my conscience. And I've seen a lot, and I was like, oh my gosh, I saw the situation, and we're going to talk about it at 4 p.m. on the live stream. But a situation that just like, it had me almost on the point of tears. Like, I was like, oh my, did that just happen? Did I just see that in the trauma bay? And so we're going to talk about that too tonight at 4 p.m. because it kind of goes to these expectations of your life. So we're going to talk about it, kind of crazy stuff. But anyway, everyone, have a good night slash morning slash whatever time this is. And as always, guys, subscribe to the channel. Like this video. If you're on here right now, like the video. It takes 2 seconds. Like the video. Subscribe to the channel. And then get over to premedproductivity.com, which is my website, and check out a course. Start with From the Bottom of the Premed Pack to Stanford Medical School in 21 days. It's 16 bucks. It's affordable and it's life-changing. Andrew said, for those who are inspired by this video and are new, Dr. P is amazing. I watch his videos all the time instead of Netflix, and don't even get me started on his courses, right? They're bomb. So you guys take advantage of that. Oh, the other thing, at 4 p.m., real quick. Hey yo. On social media, I'm also at Dominate Premed. But listen, 4 p.m., you're going to want to be there because I'm giving away a free course. So at 4 p.m., for you guys who've been waiting to get in one of my courses, I'm giving away a free course to some lucky person who's on the stream. We're going to have a contest. And actually, every Sunday from now on, we're going to be doing giveaways because I want to celebrate you guys who come out and support me when we're on these live streams. And if you guys have been to my events, you guys know I always give away free stuff at my events because I appreciate you guys, giving up your time and trying to get some of this information. So free course being given away. Devin, just a drawing or some other requirements? Well, I don't know. I don't know. I'll have to see what I feel like making you guys do to get these free courses. We'll have to see. But that's at 4 p.m. Pacific Standard Time. I'll see you guys. It's going to be a great talk. Going to be a giveaway. Be there. And everyone, have a good night, man. Let's take a step back. You know what critical care and trauma makes you realize? That life never ends on time. Okay, as if you're going to end up in my trauma bay tomorrow. Because the number one thing I hear from families is, this is just so unexpected. She had so much life to live. So don't let that be you. Let people say, oh, you know what? You know what? Andre had a full life. If this is his time, this is his time. We're good with it. So anyway, I'm out of here. Later. Raul. Later, guys.